Hi, everyone. Welcome in. We will be starting soon. Um, the webinar will be starting shortly. We're just allowing some people to come in. Okay, so welcome to the Work, Health, and Inequality towards a Comprehensive Approach to Work as a Social Determinant of Health. So a few housekeeping items first. You will be muted during this presentation. If you would like to ask a question, please enter it into the online Q&A box. We will save time at the end of the presentation to address as many questions as possible. This presentation is being recorded and will be made available on the Center for Occupational and Environmental Health YouTube page. And all participants who are logged in with their registration email for the full live presentation today will receive an email tomorrow with a link to an evaluation form that will qualify participants for a certificate of completion worth 1 continuing education contact hour. And once the evaluation is completed, you will be able to access and print your certificate. So at this time, we are pleased to welcome our presenter, Michael Flynn. Mike is an applied anthropologist with over 25 years of experience working on issues related to social inequality. Related to social inequality, both domestically and abroad. His interests include health equity, organizational cultural change, translation research, and social determinants of health. He currently serves as the lead social scientist with the National Institute for Occupational Safety and Health, where he coordinates the Occupational Health Equity Program. He is also the project officer for a research program to better understand and improve the occupational health of immigrant workers. And he also has a master's degree in anthropology from the University of Cincinnati and is currently pursuing a PhD in anthropology at the University of Kentucky. Thank you for joining us, Mike, and I will pass it to you.
Thanks so much, Tyra, and thanks everyone for organizing this and having me here for what's the third of the series of 3 talks. Just by way of some housekeeping before I start, you'll notice that all of the images on the slides as we move forward have hyperlinks in them to the articles or the websites that I'll be citing or talking about in case you want more information. And I'll send these slides on so they can be distributed to the group after I'm done. So without further ado, I'm going to get started here. So I think, as I mentioned in previous talks, occupational health is currently undergoing a paradigm shift. And I think traditionally occupational safety and health has evolved into a technical field that's been guided largely by the biomedical model of health. And this biomedical model, what it does is it seeks to isolate single proximate factors that cause an injury or illness, an injury event or an illness. And this is what it's part of what Paul Farmer calls the desocialization of scientific inquiry, which is basically the asking of only biological questions of what are often biosocial phenomena, right? However, the broader understanding of the link between work and health, the restructuring of work, known as the future of work or the 4th or 5th industrial revolution that we're currently undergoing, and the growing awareness of diversity and social inequality in society writ large, as well as public health and occupational health in particular, are all highlighting the need to expand and complement this reductionist view of cause and effect contained in the biomedical models, and expand that to account for the social, political, and economic context that contribute to health outcomes. Now, work has been fundamental to the development of the social approach to health for a long time. In fact, increased levels of disease and poverty among workers during the first industrial revolution led to the exploration of how social and economic conditions affect health, disease, and the practice of medicine. Probably one of the most exemplary studies of this is Virchow's study of typhus among coal miners in the mid-1800s. However, despite these roots, work has become less prominent in public health research and practice over the years. And this has led to a distinction between work and non-work related exposures and outcomes, which serves today as an artificial line of demarcation between occupational safety and health and the rest of public health writ large. And so one of the goals of the Occupational Health Equity Program, together with many others in occupational safety and health in general and across NIOSH as well, is working to reintegrate a biosocial approach to occupational safety and health and public health. And sometimes what we often say is the best way forward is to look back and see what was done previously. Central to the move to a biosocial approach to occupational health is the idea that how we structure society along social axes like race, ethnicity, class, gender, nativity, how we structure industries and our organizations through things like the competitive bidding process or subcontracting practices where larger companies subcontract risks to smaller companies, for example, and how we structure jobs through things like employment arrangement or shift work or compensation, right? All impact the distribution of work-related benefits and risks throughout society. And oftentimes, the structural disadvantages associated with any one of these particular arrangements often interacts and overlaps with structural disadvantages in another one of these arrangements, in what we've termed overlapping structural vulnerabilities for workers. The Occupational Health Equity Program that I coordinate, our mission is to identify and reduce avoidable differences in workplace injury and illness that are closely linked with social, economic, and environmental disadvantage. A central component is that we accept social arrangements, which can be modified, actually contribute to the inequitable distribution of positive and negative work-related health outcomes. And the central point here is that because social arrangements can be modified, that's how we get to the idea that these differences are avoidable. Because if we structure these social arrangements in a way, that necessarily implies that we can restructure them in other ways that would result in a more equitable distribution of health across populations. Right? And of course, social structures are continually renewed and restructured every day. The role of women was very different today than it was 30 or 40 years ago. Similarly, what it means to be an undocumented immigrant today is very different than what it did even 20 years ago. And so we see that society is continually restructuring itself. The question is, how can we intervene in that restructuring to contribute to a more equitable distribution of health outcomes? So the three key areas of work that we do in the Occupational Health Equity Program is one, and kind of our bread and butter, or what we started doing, is research focused on work-related health inequities. And so the second is, and what we started coming to more recently, is trying to identify exclusionary research practices and identifying inclusive research models and practices and how to best integrate them into occupational safety and health research to ensure that the results of that research benefit all workers. And then finally is promoting the idea of work, the relationship between work and health inequities writ large across all of public health, which is what I'll be speaking about today. Now, as I mentioned at the beginning of the presentation, this is the final of three presentations that are based largely on the article here to the right that talks about this paradigm shift. And you can find recordings of the other two presentations on the links in the list above. When we look at it, work as a social determinant of health inequities, we divide it into three main areas. The first, we start looking at work as a fundamental cause of health inequities. As I mentioned earlier, occupational safety and health in the United States as a field is dedicated largely to traditionally been dedicated to identifying and eliminating physical, chemical, biological, and more recently, psychosocial workplace hazards. The evolution of the field has been significantly guided or impacted by the creation of a regulatory structure in 1970 with the passage of the Occupational Safety and Health Act, which created not only OSHA, but also NIOSH. And the implementation of this act has led to significant reductions in fatal and non-fatal workplace injuries over the years. A key element of this act was it created the potential for legal liability for employers, which may have inadvertently contributed to the distinction of work and non-work related exposures that I spoke about earlier. However, changes to public health and work challenge this traditional approach and the division, right? I mentioned the future of work and the changing nature of work related to the fourth and fifth industrial revolutions, and also the predominance of the social determinants of health concept or model that was, published by the World Health Organization in 2008. Now, of course, the social determinants of health, as I mentioned, as this concept, although not the term, has been around since the mid-1800s at least, right? But I think when we look at the institutionalization of this concept, I think we can take that 2008 article by the World, report by the World Health Organization. It's kind of a line of demarcation, and where we see after that a significant move towards institutionalizing these concepts in public health organizations, including occupational safety and health. And so really you're looking at, less than 20 years, probably more around 15 years since that's actually happened, which isn't a long time when you're thinking about institutional change. Now, the World Health Organization definition of the social determinants of health are conditions in which people are born, grow, live, work, and age. And so we notice that work is already included in that, very brief definition. These conditions, of course, are shaped also by the distribution of money, power, and resources across society and in between societies. Now, the five traditional and by and large existing domains of the definition of social determinants of health by the World Health Organization, which have been adopted across public health, are one, economic stability; second, the built environment; third, the social and community context; fourth, education access and quality; fifth, healthcare access and quality. And so, as I mentioned earlier, work has long been acknowledged as a social determinant of health. And we can see in the first three above, it's explicitly mentioned as a subdomain or in the description of each of those three. And we can also see, it doesn't take much conceptual thought to see how it's also significantly related to education access and quality, because the quality of your parents' job probably determines the neighborhood you live in and the type of school you attend, right? And then, of course, in the United States, work and access to healthcare or health insurance are intricately linked, right, and have been for a while. However, the concern, and so while it's encouraging to see that work is listed in three of the five and also relevant to the other two, the fact that it's been listed as a subcategory or simply mentioned in the descriptions of each of these, I think leads to a conceptual dilution of its role or our understanding of the real impact that work has on health. And as all of us know, that the influence of work goes well beyond the working conditions, because at the end of the day, work is a major factor in circumscribing, one's life. At the physical level, it impacts significantly the income and economic resources you have access to, the type of house and neighborhood you live in, and your access to health insurance. At the emotional level, it impacts things like your self-esteem, stress, etc. And on the social health, regarding social health, it impacts things like your status in the community, your connectedness with other people and institutions, the free time you have and when you have it. And it oftentimes influences your peer group as well. Work also impacts fundamental causes of health status, such as power, money, prestige, and social connection. This is just another way of saying that work is not only a social determinant of health itself, but it also influences other social determinants of health. And work is seen as the World Health Organization pointed out, as a principal mechanism for securing the needs that underpin action on health inequities, right? Now, all that being said, we see that work plays a significant role, and at least in words, is recognized as playing a significant role in addressing health inequities. However, to achieve or realize or better understand what that potential is, we need a more nuanced and complex causal model, right? First, we need to expand our concept of risks and outcomes and avoid the artificial line of demarcation between work and non-work related, right? We need to understand that work not only affects the health of workers, but also affects, the type of job you have affects your family's health and your community's health as well. And we also need a deeper understanding and a more nuanced understanding of the interactions and relationships between work and the other social determinants of health. So, unfortunately, work remains largely absent from examinations of health inequities, right? At the conceptual level, or I guess conceptual limitations impact how we perceive work's role. So as I mentioned, traditionally work is generally seen, even in the social determinants of health model, as focusing specifically on workers and their workplaces. Also, work, as I mentioned, is subsumed under the other social determinants of health, under the 5 domains, and so therefore can often get lost in the shuffle. So one of the things the Occupational Health Equity Program, along with many others at NIOSH and across occupational health, has been doing is we've developed some language around work as the 6th domain of the social determinants of health. And just earlier this year, I think in June or July, the Community Preventative Services Task Force, which produces the Community Guide, has added employment and job characteristics as the official 6th domain of their definition of the social determinants of health. And you can find a link to that on the image here on this slide. And also the CDC Health Equity page has recently incorporated work as the 6th language around work as the 6th domain on their webpage as well. So next steps is one, we're trying to push for a broader adoption of work as the 6th domain in different definitions of the social determinants of health. And also we want to promote a greater consideration of work in health inequities research so we can get the data that we need. However, an overarching problem to get this data is that there's limited work-related data collected by public health systems. I think many of us are aware that there's no comprehensive data collection about work and health in the United States. And the data collection that do incorporate work-related items are often either limited or inconsistent. And so what our program's currently doing now is we're reviewing a select number of CDC-sponsored data collection systems to identify which work, to what degree they incorporate work-related variables, which hopefully leads to some recommendations on how they could do a better job of incorporating those so we can get some better data. In order to facilitate the incorporation of work-related variables, NIOSH has developed a couple of things. First, we've worked on developing standard questions to collect industry and occupation data that could be adopted or incorporated in other systems. And we've also developed the industry and occupational computerized coding system, which is an artificial intelligence system that takes open-coded or open-ended fields of industry and occupation that can be collected in surveys, puts them through an algorithm, and then can assign those open fields, NAICS codes to those open fields. So improving data collection on work would, one, not only improve the capacity of occupational safety and health research and surveillance to look at work-related inequities, but also would facilitate the inclusion of work and health inequity research writ large. Despite these obstacles, we have been able to do some work in this area. For example, we've been able to identify which workers are placed at higher risks for chronic conditions, for example. And so using the behavior risk factor surveillance system, we looked at some researchers at NIOSH have looked at home health care and nursing home patient care aides, found that the characteristics of this working population were high percentage were Black, Hispanic, female, and older workers. They generally had poorer access to health care and had a high prevalence of multiple chronic conditions. And so what we're able to show with these surveys was a relationship between this working population and increased rates of chronic conditions, for example. And the public health value, of course, is this identifies workers with a higher need for specific resources and intervention. But of course, there are limits to this approach, right? As we mentioned here, we also need to promote the idea of work and the causal pathway of health inequities, or explaining. So while the first example explained, showed a relationship of these workers seem to be at higher risk for these conditions, right? What we need to find is answer the question. So we can answer the question of who, but now we need to answer the question of why. What is it about work, or how does work interact with, or fit into this causal pathway of these health inequities, right? And so some of the work that's been done at NIOSH, led by my colleague Kaori Fushishiro and others, and you'll see the articles here on the side, looked at the relationship between how work can help explain the relationship between the education gradient and mortality. And basically, how it explains the association between education and health. The idea being that, better education equals better jobs, which would equal better health. However, what it found is that higher education doesn't necessarily confer the same benefits of access to safe and higher quality jobs, specifically because those benefits were often modified by race and gender, which led to demonstrable inequities in late life cognitive function and all-cause mortality. And so what the authors found, that the relationship between work and health inequities, there's a need for a line of research on this and really rooting work in the causal pathway of health inequities. In order to do this, what we need is a clear conceptualization of often overlapping terms and concepts like socioeconomic status, race and ethnicity, gender, and work. We also need to this will help us develop a more nuanced and complete causal models, and helps explains work impact on health inequities. Moving even beyond this and understanding work in the causal pathway of health inequities, we also, in this article that I have highlighted here, we tried to expand even that and tried to understand how does work circumscribe life in general, which helps contribute to not only health outcomes within a population, but also may intervene with public health interventions to try and address those inequities. And so we looked at the relationship between migration, work, and health. Specifically, it was a literature review among the health of immigrants coming from Mexico to the United States and those that returned. And so what we found is that we needed to expand our understanding of what work-related meant, right? Traditionally, work-related meant things that were associated with a specific job or industry or occupation. But when you consider immigrants, the search for work drives much of the immigration from Mexico to the United States. And so if work is your objective to migrating, and you wouldn't migrate if there weren't jobs here to be had, you could really conceptualize that all of the social context that immigrants take on when they arrive in the United States, in one way, shape, or form, is significantly related to their search for a job, or could be considered, work-related. We also found that we need to expand our understanding of whose health we're talking about. Traditionally, migrant health and occupational health with immigrant workers has focused on the workers. But we also need to consider, how those jobs impact the families of the workers and the communities in which the health of the communities where they settle, and also where they're from. And then we also divided it by looking at, focusing on, not only those that migrate, but what about those family members who stay behind, or those who have migrated and then return back to Mexico? And how has that search for work in the U.S. impacted their health upon their return? And then we looked at expanding our understanding of how the health is impacted, right? As I mentioned before, we looked at physical characteristics like lifestyle changes associated with low-wage work when immigrants arrived here. We looked at emotional impacts on extended family separation. So what was the impact, for example, on children who had been left behind in Mexico as one or both of their parents migrated for work? And in fact, I think there was a study that showed among sixth graders, I believe it was in Durango, in the select sample, I think over half of the children in sixth grade had at least one, if not two parents, residing full-time in the United States. And so clearly that has an impact on the emotional health, both of the parents and the children. And then we looked at the social impacts, right? And we looked, at, for example, there was a study, an anthropological study done that looked at, immigrant workers who had been injured or disabled as part of their job in the United States, who then returned to their home communities and their families, and how that return and then no longer being able to produce or work or be a productive member of society in terms of working changed their social role and that of the social roles of their entire family, and how they were, and some of the coping mechanisms that were used to address those social changes in the community, which often led to substance abuse. And finally, we looked at an expanded understanding of the relationship between work and other social determinants of health. And we really wanted to highlight here that there are positive and negative impacts of work as a social determinant of health for immigrant workers, right? One, you can have increased access to economic resources, right? You may give you a sense of accomplishment, particularly if your goal was to come here and get a job and you're actually successful in doing so. It can help your physical, situation in that it might lead to improved housing, or oftentimes immigrants send money back home to their communities and their families to build better housing in their home communities. But on the negative side, it can add to social isolation and economic insecurity. That even though the job you actually have may pay pretty well, right? You're often a temporary worker, and so there's no sense of any ongoing, economic stability there. And then, as I mentioned, the impact on changing family roles. And oftentimes these negative and positive impacts can happen simultaneously and overlap with one another. So the second key area that we look at when we think of work as a social determinant of health is work as an intervention. So we want to go beyond this idea of work simply causing social inequalities or causing health inequities, but work as a social location, but really conceive of work as a social location or how it can be used to improve, or an intervention to improve health, right? And we look at this in work as an intervention on an individual, organization, and societal level. One example of this would be the NIOSH Total Worker Health Program, which is really an excellent example of how a broader understanding of the relationship between work and health can be integrated into the field of occupational safety and health. And this paradigm shift from OSH looking specifically at the safety of workers or preventing accidents to work as promoting their well-being, beyond just preventing accidents. So at the individual, when we look at health promotion programs, we're really looking at the individual level. Work is generally seen as a good place to reach individuals, a captive audience, if you will. And oftentimes what the result is that these are on-site health promotion programs. So like a smoking cessation program sponsored by the employer, or, putting a gym in the offices there and encouraging people to use it. Some ways that employers, improve behavioral change in their employees is through promoting this idea through competition. So in NIOSH, often once a year we have, one of our buildings in Cincinnati compete with the other building to see, what number of employees can do the most amount of, which of the two buildings has employees doing the most amount of exercise, for example, the most number of hours of exercise in that month. They can facilitate this through things like, increasing infrastructure through, implementing sit-stand workstations, for example. And through programs, like I was in a grocery store the other day, and at the top of the hour, an announcement came on, all our associates, it's time for your 5-minute stretch break. And they would go through the associates who weren't busy would do their stretches to keep themselves limber and then go back to work. Of course, the limitations of this is that we're speaking by and large on behavioral change at the individual level. And when we talk about social determinants of health, of course, we're talking on social structures that supersede or go beyond or are larger than individual choices and behaviors. So the second level we look at when we look at is, at the organizational level, is the idea of improving health through improving jobs, right? Basically, what we're looking at here is the structuring of the employer-employee relationship and how that may contribute, or how that can be restructured to contribute to employee health or worker health, right? Through things such as employment arrangements, job security, and compensation. One example I'd use to wrap your head around this would be the idea of a professor, right? In the current higher education, you can, there are adjunct professors, and then there are tenure professors, right? And for those, for myself who has a job at NIOSH, and the Center for Occupational and Environmental Health might want to hire me as an adjunct professor and teach a class, once a semester, that might be a perfect arrangement for me because it may give me a sense of fulfillment. It may give me some additional income, and a platform to talk, which clearly I like to do. But if I were to have lost my job at NIOSH and we're looking for full-time employment, that same setup, I would probably prefer a tenure track position or a tenured position because it would provide a level of job security, probably compensation, that are different than the adjunct. And so really we have to look at what are the conditions of the work, what's the individual worker looking for, and then how is the job arranged to facilitate that, and improve their health and avoid things like stress through job insecurity and whatnot. We also look at things like company practices within the current system or legislative structure that we have. So we look at things and can compare, the company culture and values, is worker health and well-being a central core value to the company, or is it simply tangential as an adjunct, approach to let's just prevent accidents from happening, right? And this goes to things like the idea of corporate responsibility and that movement that's currently going on. Of course, the scope of this is much larger than simply individual behavior change. And it not only impacts workers, but improving workers' jobs also improves the health of, theoretically, it may improve the health of families. If a worker is making more money, and whatnot, then that trickles down to the family well-being as well. And then you can see here the case that Bruce Sherman out of, I think, Case Western Reserve makes, is how some how some employers in the healthcare industry are now looking at their human resource policies through a social determinants of health lens and are trying to intentionally make some decisions on how can we improve the social determinants of our employees' health by things like raising the minimum wage at our organization and things like that. And so in short here, the general concept or idea is that better jobs equal better health. Of course, on the structural level, when we talk about, improving health through policy. So I mentioned in the previous one, we're talking about how organizations operate under the current system. This idea is looking at how do we change the system, right? So that all organizations are encouraged to participate and restructure things at a different level. So the idea here is that we look at public policies structure the way the economy operates. And so when we talk about policies, we need to go beyond just looking at public health policies, but really studying all kinds of different policies through a public health lens. And so, for example, labor policy, right? We can look at things such as labor market segmentation and workforce development initiatives through a public health policy lens that looks at things like how the minimum wage or paid family leave legislation may impact the health of communities and workers, in a specific location. We can also look at industry's practices and regulations, right? Basically, how the rules, these are basically the rules of the game that companies operate under. And so it's not just looking at the behavior of one company and trying to convince that CEO, of changing the way they behave, but saying, okay, now we're all going to operate under this. Something akin to Obamacare, right? And requiring employers to provide, some level of health insurance, right? Or the industry practice currently of externalizing costs, risks, and liability from larger companies to smaller ones. And how does that impacting health? And how could we, intervene in that dynamic? And in doing so, how might that improve the health of workers, right? And so the basic question we're left with, or the idea here, is that policies and practices are social constructs that are built and made and can therefore be rebuilt, restructured, and remade. And so the real question is, how can they be restructured to improve public health? And of course, with better data, we have better answers to that question. And so the final area of work as a social determinant of health is thinking of work as a conceptual bridge. So what we mean by this is that, development initiatives, often don't consider public health factors as they go about doing their work. right? So we look at society and we see that we're very much in a siloed approach, which oftentimes make public health considerations seem irrelevant to workforce development projects or corporate responsibilities, right? And so if you can see by the example of the article here, part of the data we collected for this article, we actually asked some workforce development professionals, how they saw their work or if they considered the public health ramifications of the workforce development work that they were doing or the economic development work that they were doing. And at best, what we saw was that, some of the respondents said they saw it as tangential or could see the conceptual relationship, but it wasn't something that was forefront in their projects or in the results or the metrics they were using to judge the success of their projects. And I think one of the reasons that this continues is that public health professionals don't know how to speak, in development terms. And so when we approach folks doing workforce development or economic development projects, we often don't we may not conceptualize those as relating to the impact on the health of that community. And even if we do, we aren't comfortable speaking in terms that these professionals understand to convince them of that. The other problem we have is that, is limited data. And so while we can conceptualize or theorize, or at least, gather from some of the studies I mentioned here that better jobs do equal better health, it becomes hard to prove that on a lot of levels, or at least we could use a lot more data and a lot more research to help us prove that more solidly, right? And so when we try and approach these development officials, I think what work provides, it provides a common point of reference. To the degree that we integrate the idea of work as a social determinant of health, as public health researchers and professionals, or as occupational safety and health researchers, jobs then become jobs are not only central to the discussion of development, but it allows public health officials to engage in public health outcomes by talking about how better jobs can equal or translate into better public health outcomes, right? And so what work as a social determinant of health does is it creates a common language between public health and development initiatives, and therefore it creates jobs become a directly relevant social location where policies or practices can be implemented and discussed. And so in short, work, a deeper and more sophisticated conceptualization of work as a social determinant of health provides public health officials with development of folks, and it can help them move the discussion not just from the number of jobs that will be created, but also the quality of those jobs. What types of jobs are going to be created? Are they going to be low income, temporary employee jobs with very little job security? And how might that impact the health of those workers in the communities where these, workforce development initiatives are taking place? Or if these jobs are restructured, how might that better contribute, to public health outcomes there and addressing some overarching health inequities that these communities face? And so to be able to engage some existing initiatives, what I try to identify here in this slide are some initiatives that I think that there's significant, political space for us to engage further with from an occupational safety and health perspective, but discussing things like work as a social determinant of health inequities, and in particular work as an intervention or reducing health inequities in the population. So I think one of the overarching initiatives out there that I think we could better engage with is this idea of sustainable development. We have, for example, under this rubric, the United Nations 2030 Agenda for Sustainable Development that many countries have signed on to, and actually includes work or economic security as a key component of it. But jumping off oftentimes though that is focused on the workplace again. And so jumping off of that, we can show and become comfortable with discussing how work or economic security is not only a component in and of itself, but how that relates to so many of the other, areas of the sustainable developments that are delineated in this agenda, right? We can also look at the International Labor Organization's, efforts around the decent work agenda, and for one, defining what does decent work look like and how that definition may change or be adapted to different social contexts in different countries. And also just promoting the idea that everyone has a right to decent work, And then finally, the idea of environmental justice and, the whole blue-green alliance that happened that was talked about, several decades ago. And this idea that, environmental degradation and worker well-being are both significant. I mean, the primary driver of both of those is economic activity, and specifically corporations and, economic policies. And so if we can link those two, I think there's still some increased room there politically to try and integrate this idea of improving health inequities through better work and also environmental justice. And one way to do this is looking at corporate responsibility. Another way, I guess, would be the idea of corporate responsibility. So we have the United Nations Global Compact that many organizations and companies have signed on to, particularly Fortune 500 companies. And many of these, particularly larger companies, already have activities around corporate responsibility. Many of them have offices dedicated to corporate responsibility. And they publish progress towards their corporate responsibility in their annual statements. I think I think this offers those of us interested in the relationship between work and health and worker well-being and how that impacts not only workers, but also their families and communities, of really trying to leverage those annual statements and this concept of the Global Compact and corporate responsibility to start encouraging or finding ways for corporations to incorporate improving the jobs that they're giving to either their full-time employees or through their subcontractors, and how that could help, into the activities that they run and reporting on those activities in their annual statements, right? And so in short, I guess the underlying point here is that work is a powerful yet underutilized tool in promoting health equity. I think we need to really work on improving that. And I think there's a lot of room to do it currently. And so in conclusion, I think the main points I've made here is that one, work circumscribes the life of the workers and their family and impacts other social determinants of health. It can be seen as a fundamental cause of health status, yet it's underrepresented in health equity research. Second main point is that work is a principal mechanism for securing the needs that underpin actions on health inequities at the individual, organizational, and societal levels. Yet, it's an underutilized tool in advancing public health practice and policy to address these health inequities. When understood as a social determinant of health, work can also provide a very strong conceptual bridge between public health and other important economic and social initiatives. Yet, public health professionals often don't engage these initiatives and aren't comfortable with discussing work as a social determinant of health. And so to conclude, right, the integration of work into identifying, explaining, and ameliorating health inequities is essential to reintegrating a biosocial approach to health that was originally developed back during the first industrial revolution. And so with that, I'll conclude, and I guess we'll open it up for any questions. Thank you.
Thank you so much for your awesome presentation. I definitely learned a lot. So if anyone has any questions that they would like to ask Mike, go ahead and drop it into the Q&A kind of widget here at the bottom, and then I will read them out loud and have Mike answer it. So I will give maybe like a couple minutes for people to drop some questions in. But I can start with a question. So the first question I had was, you had discussed about kind of public health officials not being fully aware of like the development process or development terminology. So I guess my question is, what are some ways that that you think that public health officials could kind of get more familiar with developmental terms or the developmental kind of work process in order to kind of bridge that gap in between public health officials and kind of work as a social determinant of health?
Right. Yeah. So I think it's a whole area of study and research and whatnot. So I think just reading in those areas, even they're just overarching conceptual articles of what is workforce development, what is economic development, what is corporate responsibility, would be a good way of helping it. But I think really what provides that bridge is this idea of, not only work as a social determinant of health, but also the concept of, better jobs equal better health. And so it's really, reading about those different fields from this idea of, if they're all dedicated by and large to work or creating jobs, right? Well, then really asking ourselves the question of, well, what types of jobs are they creating and how could those jobs be structured in a way that would contribute to improving the health of the individuals taking those jobs, their families, and the communities where oftentimes workforce development initiatives take place in, communities with large percentage of unemployed individuals, economically rundown areas and whatnot. And often, simultaneously, those communities also experience significant health inequities, And so I think the idea would be is not only asking, okay, well, how many jobs can we create, but what types of jobs are those? And are those types of jobs really going to contribute, to the health of that community? Or are there ways we could restructure those jobs, maybe by increasing, the minimum wage by a couple of dollars, or increasing, moving from a temporary, work arrangement to a full-time employment arrangement type of situation that might do a better job of contributing to the health of those workers in their communities, in addition to just creating numbers of jobs.
Thank you so much for that answer. I think that's
Sure.
Totally makes sense. So we actually do have a question. So the question is, do you think the pandemic has created a greater breach on the lack of occupational health and safety?
Oh, I think if there's one silver lining to the pandemic, which sounds very odd to say, but I think it really has highlighted the relationship between work, health, and in inequality or inequity in society. I think there were a lot. During the pandemic, you saw there was a lot of press data, and I think that's both, in the population writ large and also within public health. I don't think it's a coincidence that, we've been able to add, work as the sixth domain of the social determinants of health this past year. I mean, we're standing on the shoulders of giants. People have been trying to do this in occupational safety and health for years, if not decades, right? We just happened to be, it's just this time that we ran into the brick wall, there was a little bit of a crack in it, And so I think it really has highlighted that, whether it be the front page attention that a lot of the immigrant workers in the poultry and meat processing, industries faced in terms of COVID, or just essential workers writ large, and who had to go to work and who could stay at home and still work, and who lost jobs because they couldn't go to work, but they weren't essential, and how that broke down, often along racial lines or along nativity or along gender lines. I think we're really living in a moment that offers up significant opportunities to push this specific agenda forward. So yeah, I definitely think it's related, and I think we're trying to capitalize on that as much as possible.
Thank you for that. So the next question is, in what ways do you think policies can shape the inequities experienced by immigrant and refugee workers?
Oh, in what ways policies could do that? Well, I think
Yes.
it would look at it, it looks at the type of policies you're talking about, So for example, if you're looking at labor policy, immigrants are workers like any other worker. So, raising the minimum wage, or, instituting mandatory family leave, or even we even saw in the pandemic where sick leave. Whoops. Hello, are you all still there?
Yes, we can hear you even though your
Okay.
video is frozen.
Oh, okay. I'm sorry. So even in the pandemic, where you saw that, essential frontline workers
So you're muted if you don't mind unmuting yourself.
Is that better?
Yes.
Okay. Yeah. So even like if workers who had access to sick leave during the pandemic were able to stay home when they were sick, which could reduce, transmission rates at work, for example. I think in terms of immigration, when you look at the way, the by and large anti-immigrant policies that have been, implemented since, roughly you can take it back to the 1980s in California with Prop 187 and 209, and moving forward to the national level, living as an undocumented immigrant today in the United States is very different than it was, back in the 1970s, for example. And the restrictions on what, the benefits you're entitled to, the enforcement efforts have increased and whatnot, clearly impacts worker health. So that would be a direct way. And then not only undocumented immigrant workers, but also people who are in a legal process of adjustment, including, legal permanent residents who are here, are often barred from or suffer consequences if they take means-tested benefits from the government as well, which was another concern during the pandemic, is that a lot of immigrant workers asked, well, if I get my shot, my vaccine for COVID, does that count as a means-tested benefit, which would then derail my immigration, my adjustment status under immigration laws? And so we actually had to get a statement from Customs and Immigration Services saying, no, this will not impact, this doesn't count as a means-tested benefit. So yeah, those are two that come immediately to mind, but I'm sure there are many others as well.
Yeah, I actually had a follow-up question. Kind of thinking about if we're looking at work as a social determinant of health, I'm kind of curious, have there been conversations about people being classified as independent contractors versus employees, and kind of what are the implications of that in regards to health outcomes?
Right. So a common practice in industry, particularly when I talked about, externalizing costs and risks from larger companies to small ones, we also see, if we're looking at it through the immigrant lens, companies will also externalize the risk of hiring undocumented immigrants by basically falsely claiming that their workers are independent employee or independent contractors, and they'll make them fill out a 1099 form saying, no, I'm an independent contractor, I'm not employed by this, company, even though 90 to 100% of all their work comes through that company. And what this does is it not only alleviates the company, relieves the company from any responsibility for workers' compensation and other standard labor laws that apply, but it also, helps protect them from accusations. Basically, they don't have to check the migration status or the work permits of these individuals either. And so I think those, may not be law. Well, I guess there are laws, but they're also just practices of 1099 people, and this externalization of cost and risk from larger corporations to not only smaller ones, but now to individual workers, is another policy consideration or industry practice that I think, I don't know that I have any data that suggests, that specifically explains what chronic or acute condition is contributed to by that, except for maybe, but, clearly there, it seems like there might be a relationship there. And I think you do hear in some of the research we've done, even though it's been largely qualitative, is that people do feel less secure, in those types of relationships, which can lead to them taking shortcuts to safety on the job to increase their productivity and, continue that relationship with that, employer or contractor.
So we have two more questions left in the last 5 minutes, and they're really good questions. So I'll zoom through the first one. So the first question is, okay. So as more information comes out about biosocial variables in public health studies, do you see the potential for some corporations using this information to avoid accountability and liability? In other words, some individual corporations may try to label specific health outcomes in their employees as a social issue. if this is a potential, how can we combat this trend to encourage a move towards more voluntary corporate responsibility? That was a lot, but that's the first question.
Yeah, I mean, in short, I would say, yeah, there's always that possibility. And I think, like I said, that kind of the artificial conceptual divide between work-related and non-work-related, although I'm not a historian and don't have any evidence of this, at least to me, it makes sense that that may largely been driven or at least contributed to by the potential for legal liability. So I think it could work the other way too. I think that would be a great paper or conceptual study for some folks to start thinking about and seeing, well, how do we do it in a way that doesn't result that and actually goes, the other way to help address health inequities instead of relieving, folks from their responsibility for work-related, events.
Gotcha. And so the last question is, thank you for your presentation, Michael. Is NIOSH working with the CDC Office of Minority Health and Health Equity to have work added as a sixth domain? Also, are there any potential funding opportunities to encourage states to do more research or interventions with work as a social determinant of health?
Yeah. So the answer to the first one is yes. We work closely with the Office of Minority Health and Health Equity at CDC for a long time now. As I mentioned, I guess I didn't mention it, but that health equity page for CDC is actually run by that office, and they've included language on work as a sixth domain. We're getting them to kind of refine that language and align it more with the other language that we developed for the community guide folks. But yeah, they're very interested in this, and they've highlighted work as a social determinant in various fora. In terms of funding for this, one, I think you could start looking at, maybe funding through the Total Worker Health Program at NIOSH if you're looking within occupational safety and health. But I also know that the NIH has also had, I think, at least one workshop now on work and the relationship between work and health disparities. And so I think they may actually, if I'm not mistaken, I thought I saw a funding call come out from them several months back to look at funding some research, I guess more from a public health end than occupation. They're obviously more public health than they're occupational safety and health. But that's coming from the Health Equity Office there, I believe. And so I think it's starting to bubble up, but I'd look at NIH in addition to the Total Worker Health funding opportunities at NIOSH.
Okay, I think that's all the time we have for questions. So thank you so much, Mike, for being here. And we just appreciate you coming in and sharing this wealth of knowledge. And so as a reminder to all participants that we will be sending recordings and evaluations tomorrow to all who signed in today on Zoom. And thank you for your participation and support of COEH.
All right, great. And I'll try and get the slides out to you probably next week when I get back to the office.
Gotcha. Okay.
Right.
Thank you
Thanks,
so
everyone.
much. Safe
I've
travels,
enjoyed it.
Mike.
All right. Bye now.
Bye, everyone.